So picture this. You're a doctor, finally finished med school. You've got years of training under your belt. And you're looking at a patient who, at least on the surface, seems completely comatose. Totally unresponsive, the whole 9 yards.
Yeah, classic case, right?
Exactly.
Yeah.
Textbookcoma.org, you think.
Oh, I see where this is going.
Because, get this, after days of this apparent coma, the patient wakes up, and the first thing they say is, wait for it, I heard everything you're saying. Turns out, it was all down to a medication mix-up. They were completely aware the entire time.
That's a wild story. It really highlights just how much we're still learning when it comes to consciousness.
Absolutely. And that's what we're diving into today, the world of coma and consciousness disorders. We'll be dissecting excerpts from Coma and Disorders of Consciousness.pdf, which is, let me tell you, a seriously intense medical resource.
It's a fascinating area, that's for sure, and complex.
Oh, absolutely. But we're here to break it down, make it as clear as possible. So before we get into the nitty-gritty of comas and brain scans, let's define consciousness itself. How would you explain it, say, to someone who's never even pulled an all-nighter?
Okay, I like that. So imagine consciousness as that feeling of I am here experiencing this. It's about being aware.
Being present in the moment.
Right. And it's not just one thing. It actually has two key parts, arousal and awareness.
Okay, two sides of the same coin. So what's the difference?
So arousal is like your basic on-off switch. Think eyes open or closed. It's about being awake or asleep. Awareness, on the other hand, that's the real meat of consciousness.
The good stuff.
Exactly. It's how you're processing information, interacting with the world around you, basically, experiencing being you.
So you could be aroused, eyes open, but not truly aware.
That's right, like a computer that's turned on but not actually running any programs.
The screen might be lit up, but it's not doing much.
Exactly. And that brings us to the more complex territory of coma.
Where things get really interesting.
A coma, unlike our friend who recovered after the medication mishap, means there's no eye-opening, no signs of awareness, no purposeful interaction at all.
So it's not just about being asleep.
Not at all. It's a critical condition, often a race against time to figure out what's wrong, and importantly, it's not a simple on or off switch.
Right, there are the different shades of unconsciousness, right?
Absolutely. Take the vegetative state, for instance. It's also known as VS or UWS.
VS, UWS, got it.
And in this state, someone might open their eyes, maybe even have sleep-wake cycles,
But no real awareness.
Exactly. Imagine a phone with a cracked screen. It lights up, maybe even shows a notification, but you can't interact with it at all. It's like arousal without awareness.
The lights are on, but nobody's home.
That's a good way to put it. Then there's the minimally conscious state, or MCS. This is where we start to see those glimmers of awareness.
Glimmers, so not quite fully aware.
Right. It might be inconsistent, like a flickering light. Maybe they respond to a command or even say a word or two, but it's unpredictable.
So with VSUWS, you might see eye-opening, but it's not the same as looking at you, recognizing you're there.
Exactly. It's a critical distinction to make.
And to make things even more complicated, there's locked-in syndrome, right?
Oh, yes. LIS. And this one's particularly tricky because someone with LIS is fully conscious, aware of everything.
Oh, they just can't.
They can't move or speak. They're physically trapped. Imagine being totally paralyzed but completely aware of everything around you.
It's like being buried alive in your own body.
It's a terrifying thought, and it highlights just how vital accurate diagnosis is.
You've got to figure out what's really going on. So what actually causes someone to enter a coma in the first place? What are the usual suspects?
Well, we can break the causes down into two main categories. First up, we have the structural culprits.
The things that actually damage the brain itself.
Exactly. Things like a traumatic brain injury, say from a fall or a car accident, or a stroke where blood flow to part of the brain is disrupted.
It's like knocking out the power lines to the consciousness control center.
A very direct hit to the system. Now, the second category, that's non-structural. We're talking about things that disrupt the brain's function rather than its physical structure.
Okay, so less about damage, more about disruption.
Right. Things like severe infections that cause inflammation in the brain, metabolic imbalances, like extremely low blood sugar, or drug overdoses that mess with brain chemistry.
So more like throwing a wrench in the gears rather than breaking the engine itself.
Perfect analogy. Now imagine you're the first responder arriving at the scene. What kind of clues in the patient's history are you looking for? It's like putting on your detective hat. You need to gather every piece of information you can. Did anyone see what happened? Was it a sudden collapse or more gradual? Did they complain of anything beforehand?
Headache, fever, confusion, anything like that.
Exactly. And past medical history is crucial. Diabetes, heart conditions, even psychiatric history. It all could be relevant. And don't forget the environment.
Empty pill bottles, signs of drug use, those kinds of things.
Precisely. Anything that helps paint a clearer picture of what might have happened.
It's amazing how even the smallest detail can become a critical clue.
Mm,
And once you've gathered those initial clues, you move on to actually assessing the patient, right?
exactly. That's where the real detective work begins.
So what's involved in a neurological exam of someone in a coma?
Well, this is where we have to be incredibly careful because minimizing any potential harm is paramount. We always start with the gentlest stimuli possible, see if we can get any sort of motor response.
Like what? What kind of stimuli?
So we might start by gently squeezing the trapezius muscle, that's the muscle between your neck and shoulder, or applying a bit of pressure above the eye. And we're looking for any response.
Even the slightest flinch, anything to show the message is getting through.
Exactly. If there's no response to those gentler methods, we might try something a bit stronger, but always with the goal of minimizing discomfort.
So you're not just looking for movement, you're analyzing the type of movement too.
Absolutely. The way someone moves can tell us a lot about where the problem might be. For instance, if someone stiffly extends their arms and legs, that's called decerebrate posturing, and it suggests damage lower down in the brainstem.
So these subtle differences in movement are like a secret code telling you what's going on in the brain.
That's a great way to put it. We're trying to speak the brain's language, even when the person can't communicate with us directly. And after checking for motor responses, we shift our focus to the brainstem reflexes.
Brainstem reflexes, what are those exactly?
Think of them as our window into the most basic, primitive functions of the brain. They control things like breathing, heart rate, even our sleep-wake cycle. So we're essentially checking to see if those fundamental systems are still online.
Like checking the foundation of a house, making sure it's still stable, even if the rest of the structure is damaged.
Exactly. We're looking for those flickers of life at the deepest levels. One of the first things we check is pupil size and their reaction to light.
Okay, so if someone shines a light in their eyes, do they constrict?
Exactly. It's a basic reflex, but it tells us a lot. For example, if one pupil is blown wide open while the other is tiny, that could indicate pressure on the brain.
And that's a major red flag, right?
Absolutely. It means something's pushing on the brain, and that's a situation that needs to be addressed immediately. We also do something called the doll's eyes maneuver.
Okay, I've heard of that one. And I have to admit, the name always creeps me out a little.
It sounds a lot more alarming than it actually is. Basically, we gently move the patient's head from side to side.
Oh, they're still unconscious.
Yes, but we're very careful. And as we move their head, we're closely watching their eye movements. Now, if the eyes move in the opposite direction of the head movement,
Like they're trying to stay fixed on something.
exactly, it suggests that the brainstem, which controls those automatic eye movements, is still intact.
So it's like checking if a doll's eyes are painted on, or if they're actually connected to a mechanism. Like you said, a little creepy, but hey, if it helps.
Whatever works, right? Another reflex we assess is the corneal reflex.
What's that one test?
We're basically seeing if the patient blinks when we lightly touch their cornea, the surface of the eye, with a saline-soaked cotton swab. Again, it's all about those automatic responses, those hardwired reflexes. They can tell us a lot.
Even when the person can't tell us anything directly.
Mm-hmm.
So you're checking for these subtle movements, these reflexes.
Yeah,
But you're also trying to figure out what caused the coma in the first place, right?
exactly. It's like putting together a giant puzzle. And to get the full picture, we need to use all the tools at our disposal.
So what kind of diagnostic tests are we talking about?
While imaging is critical, a CT scan is often our first line of defense.
CT scan, so like a super-powered X-ray.
Exactly. It's fast, it's widely available, and it's great for spotting major problems like brain bleeds or swelling.
So if there's something big and obvious going on, the CT scan will usually catch it.
Right. But sometimes we need to zoom in closer, get a more detailed look at the brain's intricate structure, and that's where the MRI comes in.
So it's like the difference between a standard definition image and a high definition one.
Perfect analogy. An MRI can pick up on subtle brain injuries, areas of stroke, infections, things a CT scan might miss. And what's really cool is that we can use special types of MRI, like diffusion tensor imaging or DTI.
DTI, okay, that one sounds pretty intense.
It is, but it's also incredibly powerful. You see, DTI allows us to visualize the white matter tracks in the brain.
White matter tracks.
Think of them as the brain's superhighways, the information channels that connect different regions of the brain.
So if the brain is like a complex city, the white matter tracks are the roads and highways connecting everything.
Exactly. And with DTI, we can actually see those pathways, assess if they're damaged or intact.
So if there's a blockage on a major highway in the brain, DTI would be like having a traffic helicopter, showing you how to navigate around it.
You've got it. And by understanding the extent of damage to these neural pathways, we can make more informed predictions about the likelihood of recovery.
It's like we're moving from using paper maps to navigate the brain to having real-time GPS.
Exactly. It's cutting-edge stuff. And it's not just imaging that gives us clues. Remember those blood tests we talked about earlier? Those can be surprisingly insightful, too.
Oh, right. They seem pretty basic, but I know you've got some wild stories about what those vials of blood can reveal.
Oh, for sure. For instance, after a cardiac arrest, we often look at a biomarker called neuron-specific enolase, or NSE.
Neuron-specific what now?
Neuron-specific enolase. It's a mouthful, I know.
Just a tad.
But basically, when brain cells are injured, they release this substance, NSE, into the bloodstream.
So if we see high levels of NSE, that's not a good sign.
Right. It suggests there's been some significant brain injury and potentially a worse prognosis.
So it's like a biochemical smoke alarm for the brain. Doesn't tell you where the fire is, but it lets you know how bad it might be.
Precisely. And actually, speaking of cardiac arrest, that's an area where we've made some impressive progress in terms of prognosis.
Because unfortunately, with cardiac arrest, difficult decisions often need to be made very quickly.
That's right. We're getting much better at recognizing the clinical signs, especially those present after a few days, that are strong indicators of a poor outcome. For instance, if someone still has no pupil response or corneal reflexes after 72 hours.
That's not a good sign.
No, it's a grim sign. And then there's the EEG, something we've touched on already. The EEG can sometimes show us what we call malignant brainwave patterns.
Malignant, so like really bad.
Yes, unfortunately. While these patterns aren't necessarily a death sentence, they are often linked with a very low chance of meaningful recovery.
So it's like the brain is sending out an SOS signal, but it's a signal we hope never to hear.
In a way, yes. And when we see two or more of these bad signs together...
The clinical signs, the EEG patterns, all of it.
Exactly. It paints a clearer picture, though I'll be honest, it's often a very difficult picture.
It's like putting together a complex puzzle. You really need all the pieces to understand the bigger picture.
And even then, there's always a degree of uncertainty. We do our best with the information we have.
You mentioned something earlier, post-anoxic myoclonus. Can you tell us a bit more about that?
Oh, yes. Post-anoxic myoclonus. That one's a perfect example of why we can't just rely on appearances. Careful observation is key. So post-anoxic myoclonus is this rare condition that can happen after the brain's been deprived of oxygen, say after a cardiac arrest.
Okay, so after the brain's been without oxygen for a while, what happens?
Well, it can cause these sudden involuntary muscle jerks. We call them myoclonus.
So to someone who doesn't know any better, it might look like the person is having seizures.
It can be very easily mistaken for that. Specifically, a much more serious condition called myoclonic status epilepticus, which has a very, very poor prognosis. But, and this is the important part, with post-anoxic myoclonus, the person is often still conscious.
Wait, really? So even though they're having these jerking movements, they're aware of what's going on?
They might be, they're just not able to communicate it in any other way.
Wow. So you could have someone who appears to be in incredibly dire straits, yet inside, their mind is still functioning.
Exactly. It just goes to show you we can't jump to conclusions, not based on outward appearances and not based on a single test.
We have to consider all the evidence.
All the pieces of the puzzle, and even then, there's always that element of uncertainty.
Which is why open and honest communication with the family is so incredibly important.
Absolutely. We're not just dealing with test results and diagnoses, we're dealing with people's lives.
It's about navigating those difficult conversations with empathy and understanding. It's about remembering there's a person there, a human being going through something we can barely even fathom.
It's about recognizing that even when we don't see those outward signs, those responses, there's still someone in there. And that brings us to another really important aspect of coma care. We've moved away from that old wait-and-see approach.
What do you mean? What's changed?
Well, we now understand that how we treat the body can have a huge impact on the brain's ability to heal.
It's all connected.
Exactly. And that includes things like minimizing sedation whenever possible.
I was actually wondering about that. It seems a little counterintuitive. If someone's unconscious, wouldn't you want them to be as comfortable as possible? Why try to minimize sedation?
It makes sense on the surface. But heavy sedation, especially continuous sedation, it can actually mask those subtle signs of improvement we're looking for.
So it's harder to know what's really going on.
Exactly. Plus, it comes with its own set of risks: muscle weakness, delirium, even problems coming off the ventilator later on. We want to give the brain the best possible chance to recover. And that means finding that balance, that sweet spot between comfort and clarity.
Making sure you can see those flickers of awareness if and when they appear. What about early mobilization and physiotherapy? You've talked about that before, and you said some pretty interesting things about it.
It's amazing, isn't it, how even the simplest movements can make a difference.
You've actually called it the most important therapy in coma care. That's a bold statement. How can someone who's unconscious benefit from physiotherapy? They're not exactly hitting the gym, are they?
No, not quite, but think about it this way. Imagine a houseplant that's been stuck in a dark corner for weeks. It's wilted, drooping, barely hanging on, but then you move it into the sunshine, give it some water.
Give it what it needs to thrive.
Exactly. Our brains, in many ways, they're the same way. Even when someone's unconscious, their brain is still responding to sensory input, to movement, early mobilization, even if it's just passively moving their limbs, helping them through their range of motion.
It's like sending those wake-up signals to the brain.
Exactly. You're stimulating those neural pathways, reminding the brain that the body is still there.
So you're not expecting them to get up and start sprinting, but those gentle movements, that stimulation, it's like whispering to the brain, hey, keep fighting.
Exactly. And the benefits go way beyond the brain. Early mobilization helps prevent bed sores, improves circulation, reduces the risk of pneumonia, all sorts of things.
So you're caring for the whole person, not just the part that's injured.
Precisely. And that brings us back to the importance of communication, of talking with the family, supporting them through this incredibly difficult time.
Because as we've discussed, it's not just about the medical facts, is it? It's about people's lives. It's about hope, about uncertainty, about making incredibly difficult decisions.
Honesty is crucial in these situations. Empathy, too, obviously. But we also have to be willing to listen. Really listen to what the family is going through, what their concerns are.
Because they're grappling with so much. Fear, uncertainty, maybe even a glimmer of hope.
Exactly. And we might not always have the answers. It's important to acknowledge that uncertainty. But what we can offer is support, resources, and a space for them to process those emotions, to make decisions that align with their values.
So it's about being a guide, not just a dispenser of information, helping them navigate this uncharted territory with compassion and understanding.
That's what it's all about in the end, isn't it? Because coma, consciousness, these things aren't just medical mysteries. They touch upon the very essence of what it means to be human.
We've talked about all these incredible tools for assessing brain function. But what if we're just scratching the surface? What if there are layers to consciousness? Dimensions of inner life, of experience, that we haven't even begun to understand, let alone measure? It's a humbling thought, and it's one that sticks with you. The world of coma and consciousness is complex, it's challenging, and it's full of these incredible mysteries. It really makes you think. Thanks for joining us for this deep dive. Until next time.